welcome to the JRCPTB podcast on trainee progression and ARCPs during the COVID-19 pandemic. I'm Zoe Fleet, Head of Curriculum, and I'm very pleased to have with me here Dr. Mike Jones, who is the Medical Director for Training and Development for the Federation of the Royal Colleges of Physicians. Mike is a consultant in acute medicine at County Durham and Darlington NHS Foundation Trust. He's the Director of Training for the Royal College of Physicians of Edinburgh and the National Clinical Lead for Acute and General Medicine in the Getting It Right First Time programme.
Hello.
I'm also delighted to welcome Dr. Phil Bright, Consultant General and Respiratory Physician at University Hospital Birmingham. He's currently the Head of School of Medicine at HE West Midlands and the Clinical Advisor to HE for Internal Medicine Training.
Hello.
Last but not least, we have Dr. Seun Anyiam, who is the North West Thames Region Representative on the RCP London's Trainees Committee. He's an ST6 in endocrinology and diabetes and is currently out of programme studying towards a PhD.
Hello, everyone.
So first of all, Mike, can I just ask you to outline why we're doing this podcast, please?
Yeah, that's a very, very good question. We do know that at this time, the uncertainties that are felt by trainers and trainees about what will happen with regard to training and especially the exam situation, these are causing considerable anxiety. And therefore, we're trying to work to provide clear positions on all aspects between ourselves at JRCPTB and the training systems across the UK. We believe trainee welfare is incredibly important, and we hope that this podcast will help to provide clarity at an uncertain time and will allow trainees to plan for the coming months.
That's great. Thanks very much, Mike. So if I can start then by asking you, what impact are you seeing on the learning opportunities for trainees in terms of what experiences they can get and the assessments that they can get?
Yeah, I think it's fair to say that with this pandemic, which is of course unprecedented, and I'm sure we'll hear lots of that word recurring, but as people have been moved and redeployed to cope with the pandemic, and indeed rotations were stopped in April for those that were supposed to progress, that has changed the experiences. It does not mean the experiences are not filled with learning opportunities, because much of what we do in medicine is experiential, and the management of patients who are being admitted with the COVID-19 virus is, of course, a very important part of management of the acutely ill patient. However, assessments, especially in certain areas where there's been a very, very big effect of the virus, these have been far more difficult to come by because trainers and trainees are extremely busy providing clinical work as opposed to providing work towards their progression in training. So whilst we do commend that people try and get as much assessment and try and get as much into their portfolio as they possibly can, we recognise that these opportunities have been somewhat compromised.
So will trainees still be able to progress this year?
Yeah, I think it's very clear that we have to enable trainees to progress in their programmes. It's not their fault or indeed anybody else's fault that this pandemic has hit. People are providing a really, really good service to patients, and the fact that training has changed from what might have been projected associated with their programs is not their fault, and we need to make sure that where people have been applying themselves to providing clinical service and gaining experience, that they should be allowed to progress. Because exams have been cancelled, again, nobody's fault, but because of the situation, we have to give the opportunity to trainees to progress so that they can subsequently take the exams that are important to show that they have the basic knowledge and the applied knowledge that the exams check. So we are making sure that people will be able to progress in August as we would expect.
Great, thank you. So looking at the ALS requirements, so core trainees, internal medicine trainees, many of the higher programs, you need a valid ALS certificate to work in acute medicine, and obviously it's proving impossible for people to get their certification renewed. What should trainees do in those circumstances?
I think it's fair to say that the Resuscitation Council of the United Kingdom have already issued guidance for those that were planning to renew their ALS in the near future. They will be able to continue using their ALS certificate as it exists at the moment. But we recognise that some people would be coming back into providing clinical services when they may have been out of programme for quite some time. And we've suggested how people could show that they're still capable of providing the service that the ALS certificate demonstrates that they can. And these guidelines are on the JRC-PTB website, so that we have some confidence that trainees are able to do the work that is necessary associated with advanced life support.
Great, thank you. Okay, so moving on to the arrangements for ALCPs this year. Sean, would you like to take over?
Hi, thanks Zoe, and hello everybody. Yes, so I'd just like to ask a few questions about ALCPs, as obviously this is quite an important area of concern for us trainees. The first question I'd like to ask is, how will the impact of the pandemic be recognised at ALCPs this year? And just to follow on from that is, what outcome will trainees be getting?
Okay. We've thought long and hard about whether we should run ALCPs this summer, and we took lots of soundings off people. There were considerations given to whether trainees would be in a place where the ALCPs would be meaningful, whether trainers could meaningfully engage with the ALCPs, and indeed whether the statutory education bodies could deliver the ALCPs. Having undertaken that consideration, it was clear that we could do the ALCPs, and indeed many trainees were really wanting us to do ALCPs rather than to defer them into the autumn or later at an uncertain date and time. The important considerations in making the ALCPs happen was that we had to allow trainees to progress, but that progression had to be predicated on maintaining patient safety, trainee safety, as well as maintaining training standards and ensuring that the whole training system didn't become blocked by people not progressing, which would then have a rollback impact on more junior trainees and indeed, ultimately, on recruitment and all the consequences that would flow from that. What we've done is to adapt the ALCPs in terms of requiring the minimum reasonable amount of evidence that trainees are going to be asked to put in their portfolios, and it will be reviewed by panels. The focus is very much going to be on the Educational Supervisor Report, and certainly in England for HEE trainees, in addition to that, which is a self-declaration in which trainees will be able to outline what they've been doing during the pandemic, what they've learned and what they've not been able to learn, and also it'll act as a touch base where trainees can indicate whether they would need further conversations with their TPD. To that end, the decision aids PTB uses to assess trainees or to support the delivery of the ALCPs have been amended, and currently they're awaiting the sign-off by the GMC, but that sign-off is expected, and these decision aids will appear on the JRC PTB website. We've been very mindful that the standard outcomes you would normally expect for an ALCP won't really fit with the current situation. So we've developed a number of new ALCP outcomes which will be implemented now and will probably stay in existence for an indefinite period of time, maybe a year, maybe longer than that. And it's where a standard outcome, a previous outcome, cannot be used because of the consequences of COVID. And there are two main outcomes, an outcome 10.1, which is an outcome used in a situation which is not a critical progression point in a programme, and a 10.2, which is an outcome used at a critical progression point. The 10.1 should really be considered equivalent to an outcome 1, where a trainee is progressing well, but for reasons of COVID, the evidence can't be presented. In the context of the end of core training, it can also be considered for recruitment purposes as an outcome 6. The 10.2 is more closely aligned with an outcome outcome 3. And in that sense, it is given at the end of a training programme, usually, implies the need for additional training time. There is a third outcome which is going to be exercised potentially more in this time, and that's one of the previous outcomes, an outcome M13, which will be awarded if an ARCP cannot actually happen and has to be deferred to a later time. Along with these new outcomes will be a new appeal process. There will be a set of frequently asked questions agreed across the 4 nations and hosted on the HEE website. Following the ARCP, there will be a need for trainees who don't get either an outcome 1 or 6 to have a feedback session with a member of the panel or their TPD, in which we've asked TPDs to be very clear about what the training plan going forward needs to be for that trainee, and to support and signpost trainees to the materials needed for them to successfully complete their training.
Thanks very much for that really detailed answer. I can tell that there's a lot of factors that need to be taken into account, and there's clearly been a lot of thought being put behind all of this. Is there going to be any guidance for trainees and for trainers about all of these new outcomes in particular? Because I can imagine it's getting quite confusing if people aren't aware of what, particularly the trainers actually, at the ARCP's outcome.
We've put in place a comms pack which will be published on the 1st of May, which gives a lot of detail both for trainers and trainees, and indeed for the assessment team panels that run ARCPs. Each college has put together relevant information on their website which are more programme specific. It is thought that the frequently asked questions will be a live document. They are drawn from questions raised to us by trainees at the Academy of Medical Royal Colleges, but as other questions arise, we will put those in place. We've also got available a number of recorded training sessions, question and answer sessions, delivered by people across the UK, which will be made available as short chunks of learning for trainers and the people who support the panels. We've changed the format of the panels, so largely they will be 2-person panels rather than the normal 3-people panel. And we've also reduced the requirement to have a lay person or an external assessor. That doesn't mean that they can't have a lay person or an external assessor, but there's no statutory requirement this year for them to be in place.
Yeah, that's great. It sounds like there's going to be a lot of resources out there for people to go and to have a look at if they were particularly leading up to the ARCP. I think this has already been touched upon, but do we have an idea of the exact format the ARCPs will follow and how they'll be different to the usual process?
The ARCPs will all be done remotely. They'll be done in absentia. That is, the trainee will not be part of the ARCP process, but that's best practice as laid down in the latest version of the Gold Guide. That's version 8. There will be 2-person panels, and the outcome of that panel will be fed back to the trainee at the earliest possible opportunity. All of the colleges, including the JRCPTB, have altered their portfolios to allow for the recording of the new outcome 10. And the direction to people in the panel is to make the narrative that goes with the outcome as detailed and as directive as possible, so that trainees will have a very clear idea as to what still needs to be done and how to achieve what it is that needs to be done.
And are there any specific considerations for trainees that are approaching CCT or seize a CP date? For example, can a trainee complete training and get a CCT if they haven't already passed a specialty exam?
So here again, the principle of maintaining standards has been paramount, particularly ensuring patient safety and trainee safety. If a trainee can't meet the absolute requirements of a CCT predicated on an outcome 6, then they will not be able to get their CCT and will need to have some extended time in training. Where we can, we have reduced requirements down to those needed to maintain the principles I mentioned earlier. For those trainees that can't get the exam, the SCE exam in the case of physician training, they will be awarded an outcome 10.2 and will be given additional time in training. The exact format of that time is still being debated. It may be possible for trainees to act in a consultant locum role, in an acting up consultant role, or maybe, if the requirements are fairly minor, they may be able to progress into a period of grace with the awarding of an outcome 6, with the requirement that they undertake some additional training in their early consultant time.
Right, that's all been really useful for me, and I can see that there's obviously a lot of work going on behind the scenes to make this all work. Now I'd just like to ask about rotations and trainees moving on to other posts. Do we know if trainees will be starting new programs or rotating in August?
Trainees will be starting new programs in August, because we obviously have to ensure that there is a continuing progression for all trainees. Whether that will automatically be in August, that is also dependent upon the locality and the specialty that trainees are in, because it is recognised that certain areas will get people rotating in September or maybe October. Some of that may be very useful in trying to ensure that we have an avoidance of the August effect, where all trainees rotated at the same time and teams were decimated. And so it may be something that we can learn from this pandemic, that staggering of rotations would be the appropriate thing to do. But trainees who are coming to the end of their first year in internal medicine training will be rotating round unless there is a further change to the plans as outlined by the statutory education bodies. We are, of course, entirely dependent on the views that they take on this, but certainly, as things stand, each of the education bodies in the 4 nations is looking to ensure that rotations will occur, and trainees, I think, are fully expecting that to occur.
Just further to that, the heads of school have been asked by their TPDs to look at, where possible, keeping people within the same organisation to reduce the movements of doctors around the country in early August. Where that's not possible for good curriculum reasons, then trainees will of course move. And that good reasons would also include where trainees have a strong personal reason to move.
That's good to know, because I think there was a lot of uncertainty around trainees, or among trainees even, about whether we'd actually move or not. So it sounds that there's a lot of clarity on this issue. Similar to my earlier question about trainees that are approaching their CCT or CSER CP, trainees moving on to ST3, will they need the full MRCP diploma to be ST3 posts?
Sorry, we are very clear that because trainees who are in core medical training at the moment, for instance, frequently will not have been given the opportunity to sit summer parts of the MRCP exam, it would be enormously disadvantageous to this incredibly hard-working group of people to stop them being able to progress. So we have applied to the GMC for a derogation of the requirements that would allow people to progress in their training. So we have published on the website precisely what outcomes people should be given dependent on how their training has gone. So for CMT trainees, if they have no part of the membership, then they would not be able to progress to an ST3 post. But if they've got part 1 and have yet to successfully pass the written part 2 or the PACES exam, they will still be able to progress into ST3. For everybody, however, who has not yet attained the full MRCP diploma, it is very clear that their training will be supported but also observed carefully, because they will not be able to exit ST3 into ST4 without having that full diploma. So the concentration for all trainees who may be starting in ST3 post who do not have the full MRCP diploma is to get that diploma as quickly as it is possible for them to do so.
Okay, and finally, if an internal medicine trainee is not able to rotate into a placement in ICU or geriatric medicine, which of course are the mandated training experiences for stage 1 IMT, how will this affect the rest of their training program?
That's a very good question. I have to take a small issue with you in that we can't mandate any training experience, but what is laid out very clearly in the curricula that PTB generates are the fact that there are certain learning outcomes. And therefore, if those learning outcomes are associated with specific experiences, it would be difficult to see how those outcomes could be achieved without having a specific experience. I know that sounds a bit picky, but it's something that is very clear to the GMC, who obviously ratify all our applications for curricula. They are very, very clear about what they're wanting trainees to achieve, not the experiences or the time spent in any particular learning experience. So concentrating on geriatrics and intensive care medicine, or critical care medicine, which is probably more accurate for the internal medicine training program, we do feel that the learning outcomes for both of these specialties would be very difficult to achieve without having proper experience of these specialties. So we have had to speak with the heads of school and make sure that in the 2 years that are remaining of the training program, that there will be very significant attempts to ensure that all trainees who are recruited to an internal medicine training program will gain adequate experience in these specialties to achieve the learning outcomes that are specified within the curriculum. This is going to cause a degree of anxiety and also a lot of manipulation of training programs to make sure this is achieved. But the fact that it's now in the environment where the people who are responsible for developing the training programs are completely aware that it is a very significant part of the internal medicine training program, then we fully expect that this will be delivered. We are very clear that the internal medicine training program was developed on the back of Shape of Training, which is looking to develop more generalist type physicians, and bearing in mind the demography of the population, geriatric medicine is a very, very clear mandated learning outcome, but also certainly in the settings of this pandemic, a recognition of the acutely ill patient and the management of the acutely ill patient will be best achieved by experience within a critical care setting.
Thanks, Mike. It sounds like there's quite a clear sort of plan for the MRCP in particular, and it sounds like there's a lot of sort of flexibility that's going to be needed for the subsequent years of training for IM trainees to ensure that they meet these necessary components of their training program. Thanks very much.
Okay, so that concludes our podcast. We have an information hub on the JRC-PTB website where you can find the latest guidance, advice and resources about the training, MRCP examinations and also CPD. We'll keep continuing to update you and develop these pages to support you as the situation develops and changes. So I'd just like to say thank you very much to Mike, Phil and Sean, and thanks to everyone for listening.
Thank you.
Thanks.